So thank you so much for joining us today. We have with us Travis Turner, who is the manager of Global Patient Operations with the Houston Methodist Global Healthcare Services, Houston Methodist Hospital. Thank you so much for joining us, and thank you for sharing your experience.
My pleasure. It's my pleasure. This is a great opportunity to continue our partnership, but also to really grow language assistance the way that it needs to be, and to really put it out into the forefront of everyone's minds. Because even though COVID is happening all around us, and everyone is kind of struggling with their own personal anxieties and stuff about this, a majority of us probably on here have the ability to communicate in English, which is the most common language in our healthcare system. So having the ability to bring to light that not everyone has that fortunateness is really good for all of us to be able to acknowledge. So thank you for having me, and I look forward to learning a ton from this series.
Great, great. And as we're going through wave 2 of COVID here in Houston, I wanted to ask you, what do you suggest organizations put in place, and what are the lessons learned from obviously the wave 1 to be better prepared for language access? And some of those lessons learned, how are they leveraged in short, medium, and long term?
Gotcha. Yeah, that's a really good question. And that's actually something that we were thinking of kind of as it was happening. So I like to think of COVID, this whole experience, as a book that's currently actively being written. And so there are people out there who are actively writing the book, and there are people who are actively taking notes from those who are actively writing the book. So it gets really confusing, and there's no edits right now. So the book hasn't been read and reread and edited and all of that. So there's mistakes, there's misspellings, there's typos, there's crossed out, entire sections are crossed out. So really what we started with was just trying to conserve. So we all know that in the US, the biggest push at the beginning of COVID was conservation, was the fact that we did not have enough supplies to meet the demand. And so it really was, what could we do to conserve PPE? What could we do to decrease donning and doffing of gowns and gloves and suits, and decrease the use of hand sanitizers and hand washing and time lost doing all of that. So we really moved to a more technologically based format for our language assistance. And so one of the things that we already really had in place was, for those of you who can see me, we all carry badges, and on these badges we have a buddy badge. That buddy badge has information on it of what phone numbers to call for over-the-phone interpretation. So it's very quick and easy, and you don't have to look through your phone and fumble through this and pull out your notebook. It's just right here. It's always with your badge. It's there, ready to go. And so we leveraged kind of that thought process to create, how can we conserve PPE and still provide a very high level of language assistance? And so we put our heads together with nursing leadership, and we really tried to kind of combine some stuff that was already out there. And so we started to leverage technologies across the board, leveraging this. We already have access to this. How can we push it all together? And so conservation really was like the biggest thing that we wanted to tackle. And so we thought, our first thought process, and I know that you're going to ask me a ton more questions about where did this take you? Where, what was the outcome? What was the answer to this problem? But really, the first beginning was, how can we keep the people who are, extremely important for patient care, which is language assistance. Language assistance is extremely important to patient care. How can we keep them there, but also conserve PPE and conserve supplies? So that's kind of what our biggest issue was, and we've learned a ton from trying different things. Like I said, the book is actively being written, and we're taking notes from other people's books who are actively writing it too. So the things that we've taken notes from have been corrected, and the things that people have taken notes from us have been corrected over the past few months. So it's been definitely a learning experience, but it has been fun, to say the least.
Did you have any creative solutions or difficult or different solutions that you had to come up with dealing with this unpredictable nature of the virus? And if you do, are some of them here to stay?
Yeah, I think that the future of language assistance is going to be extremely technology heavy. I do think that decreasing the amount of people in a patient room and decreasing the amount of people that interact with patients is going to kind of be the move in the future, at least during this most recent post-COVID times. Hopefully, once we get there soon. And so we have leveraged a couple of different technologies. One that is I'm really proud that we were able to do is that all of our nurses in our inpatient units, they carry a device on their lapel, and it's like a walkie-talkie cell phone type of device. And it's voice activated. So they can say, they can call, hey, call Travis, and it'll connect them, and they can have a conversation just like that. So we combined our language assistance with that device, putting the two together and marrying them. And like I said at the beginning, the first process was conservation. How can we decrease donning and doffing of PPE in order to conserve it? So we basically eliminated the in-person interpreter in that process by providing it now on the lapel of the practitioner. So the practitioner walks in, they notice that they need an interpreter, or they're told in advance, or however that occurs, and they just say call interpreter services. Then there immediately calls and dispatches, and it works just like a phone that's on speakerphone. And something that kind of evolved from that was not an initial goal, but was a huge positive, was the lapel. The device on the lapel is positioned very closely to the heart, and it's positioned very closely to the mouth. And so when you're having this conversation with the patient, the voice is almost coming from the practitioner. And so it kind of eliminates the fact that there is a third party present, and it adds a little bit of a compassion spin to the fact that, you do have to have a third party in here. It is kind of a bridge and in between. But really the voice is coming from the practitioner and going to the patient, just like it would if they were speaking the language themselves. So I definitely think that's here to stay. That's something that was a huge positive that I saw after initiating this technology. And it really has shown that the patients interact better if it's actually coming, if it's at least seems like it's coming from the practitioner.
And literally coming from the heart.
Literally, exactly.
The device is located. Wow,
That's
that's
exactly
great.
right. Yeah. And like I said, it's not by any means something that was even a goal at the beginning. It just was a product of making something work, and then you find out, oh wow, that's actually way better than what we were doing with a phone on speakerphone, or the double receiver phones. It actually is coming from the practitioner to the patient, and it's more warm, it's more inviting, and so we pride ourselves on our eye care values here at Houston Methodist, and so that fits in really well with our eye care values.
Amazing, amazing. Wow, thank you for sharing this. This is a great point. And I don't know if many organizations who have implemented this, so this is definitely a great lesson learned.
Awesome. Thank you.
So, from the compliance standpoint of view, at this time when we had to deal with social distancing and with people not being able to come even to, hospital, we had
Hmm.
to move to remote medicine in a lot of cases, or remote encounters. How did this hinder or help? Did it hinder help language access in the process?
Yeah, so I do think that the road was bumpy at the beginning, just like it was in every industry everywhere when COVID initially raised its head. So it was a little bumpy. We did have to work through some stuff trying to make sure that we were compliant and that we were providing what the precedent is out there for language assistance. So I know that I know that sometimes people think of language assistance as a secondary thing to healthcare, and really, it's not. The Whether you are a self-pay patient or you have insurance or you're a charity case or any of the full realm of how you pay for medical services, in an operating room, the team doesn't change. So you still have the same team in there no matter what. So the idea that you don't need an interpreter present really should not be the mindset for anyone, because they should be seen as a member of the operating room team. That portion should never change. And so you always have to have the ability for the patient to understand their health care. So I really, it comes back to convenience for me and making sure that everyone has the ability and it's very easy. So we are humans. We're lazy in general. All of us are lazy. I can admit it. I'm lazy at some things also. But when it comes down to it, if you have something and you have no excuse to get around it, then you're gonna do it. It's the same concept as washing your hands. And so the way that hospitals have kind of evolved with washing your hands is they've just put um, like hand sanitizers everywhere. You can't walk 5 feet without seeing another hand sanitizer station. And so making language assistance as convenient as hand sanitizers in a medical center is really the goal for us. And my director and I, Aaron Mulper, it has become a huge passion point for us to be able to provide language assistance to anyone and everyone that needs it, and to provide it at the level that was set up in 1964. A lot of people don't understand that language assistance was mandated all the way back in 1964 with the Civil Rights Act. And so language assistance and providing someone with the language that they need and providing health care and meeting the patient where they're at in terms of their language needs is a precedent that was set in 1964, that was reiterated with ADA and then was reiterated with the Affordable Care Act with President Obama. So there really is no excuse for not providing language assistance. And so whenever we were working through how to do that with our virtual platforms and not allowing people into the rooms with COVID patients, depending on their severity and all of that, it really came down to education and education of the staff. So there's no excuse that we should not be providing the utmost language assistance for our patients. And so if you find yourself finding an excuse, then I have asked everyone to let us know, and I will personally go out and squash that excuse, because there shouldn't be one. We have them on your lapel. It's as easy as asking it to do the work for you. You don't even have to do anything anymore. You don't have to step out, grab an iPad, bring it in. You don't have to get your phone out. You don't have to do anything. It's so convenient to do language assistance now. It's there's no excuse not to provide it.
That is amazing. That is absolutely amazing. And I agree with you. Language rights are human rights. And the first
Exactly.
time you're in a hospital, either in the remote part of Africa or Mongolia or China, and you don't know what's going on and nobody speaks the language, it's, you can really understand the terrifying experience and of what a person may be going through. So I'm
Correct.
really proud that and honored to be working with you guys and partnering with you because you're uh, at the forefront of ensuring language access. You've already highlighted in a lot of points on how the role of the interpreter changed. On the one hand, making the interpreter more invisible, but on the other hand, making the interpreter closer to the heart in a way. Are there any other ways that you see that COVID-19 has changed the role of the interpreter during the encounter? And are there any tips or advice that you have for interpreters how to be better prepared?
That's a good question. Yeah, so we have been constantly and consistently working with our IT our IT department to determine what else is out there. What is there? What is already, we leveraged our language assistance platform with something that the nurses already had. How can we continue to merge things that are already here? Things that don't cost money, things that don't take a big build, that don't take, having to put it into production, and then, skip all of those steps. Just merge things that are already here, already happening. So there are a couple of things. We've added some Amazon Alexas to some of our rooms as an IT initiative to see kind of how we can do some things. Uh, and possibly adding, language assistance onto the Alexas, having an app available where you can easy access, having it have the ability to do the same thing as the device on the lapel to call the over the phone interpreters. Our interpreters have become more sedentary. Our interpreters used to be the ones who got the most steps out of anyone in any department across the system, probably. Now they have become a little bit more sedentary. They are, like you said, more embedded, more less, kind of like you said. We've moved them out of the forefront as a stand-in, as a person, and we've really merged them and embedded them into the staff. So interpretation is now just part of the person that walks into the room. It's just part of it. Doesn't you don't have the nurse and then the interpreter walk behind them or walk in separate, or the physician. It's now the nurse walks in, the practitioner walks in, and interpretation walks in with them. Same step, same everything. It's there with them. It's on their chest. It's ready to go. And so I think that really kind of adapting to that shift is going to be tough for a lot of interpreters. It has been tough for my staff they feel as though they're distant from the patient, when in all reality, they're actually way closer to the patient than they've ever been. And it is very rewarding profession. It's a very engaging profession to be there for patients in their time of need and be able to provide, like you said, a human right that everyone should have. And it's very fulfilling and very rewarding. And so just kind of finding that balance as an interpreter to remember, although you're not present, you're more present than you ever have been. And so really, really trying to make that connection with them, I think, is going to be a hard transition. But it's really important. And I think that we will be better because of this. And the quality of what we can provide will be even better than it ever was.
I really like what you shared, that the interpreters actually moved into the heart of the provider. So I'm actually inspired by that, both, as a professional interpreter and as a somebody who's been in this industry for over 30 years. That actually inspires me. Going for the first time, I am in the heart. I'm part of providing um, language access from the heart. So that's amazing. And thank you for sharing. And thank you so much for your time. And we'll look forward to, hopefully COVID will be over, but if it isn't, we will be reaching out to you again to see if there are any other additional excellent inventions. All right.
Perfect. Yeah, sounds good. Again, thank you very much for your time, and your partnership has been extremely invaluable. And all the things that I spoke about are not possible without you and your partnership. So I really appreciate it. Thank you very much.
Thank you. Thank you very much.
Thanks.